This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, everybody. Hello, and welcome back to the SimKit podcast. I am Jason Hine. We've seen or heard, depending, we're doing vodcasts, we're doing podcasts, we're mixing and matching, getting to your eyes, getting to your ears, a lot of different ways to get your medical education from us today. But you're going to be seeing two familiar faces, hearing two familiar voices. I am joined by the amazing Dylan Moore again. We are going to be talking about an interesting case he has had, interesting disease process. I don't want to spoil too much. I'm just not even gonna go into it that much here. Just want to welcome Dylan back to the show. Dylan, thanks so much for joining us.
Jason, as always, it's a pleasure to be here. I don't know why you keep signing up to hear me speak or even coordinate any of this with me, but I'm glad to be here. So appreciate you.
It's good to be, in a digital room together, right? I'm in Maine. You're, I believe, in a frying pan somewhere south, right? You're Arizona cooking away. So you staying cool, you're crispy fried. We can see your skin color, tone. We can see you're not leather brown. So there you go. That's good. But how are things in Arizona these days?
Oh, it's hot. I think it was like 115 today. So we get up there. Luckily, the best my skin can do is like a golden tinge. I wish we could do a little bit better and kind of prove to people that I do get some UV rays and some sunlight, but we're working on it. So I do have a case today, and hopefully it's a good one. Are you ready to roll?
And I am very ready to roll. Let's rock, let's roll, let's get into it.
This actually happened just last week. So let's start with the chief complaint on the trackboard. Facial swelling. You see it's a late middle-aged gentleman, ESI level 4. What immediately comes to mind for you when you see this pop up?
Ooh, the last thing you throw in, that ESI 4. So weirdly, that starts reassuring. Should it? No, shouldn't reassure you. I've seen plenty of ESI 4s that were admitting to the hospital, sometimes to step down or ICU. So it happens. You can get the sick ones. But that ESI 4, yeah, you wonder, like sunburn. We're talking about the heat. Maybe they just got a bad sunburn, facial swelling related to that. But let's talk about more serious ones, potentially. Facial swelling, middle-aged gentleman, I'm going to think about angioedema. That's certainly going to come up. And then when you throw that out there, anaphylaxis is going to be on your list as well. Anasarca, or just global swelling. And then I think about the big three organs when we start talking about large volume swelling, liver, kidney, heart disease. And then within that kidneys, specifically face, talking about eyes, nephrotic syndrome is going to come to mind. We said it was a couple weeks ago, so we're spring, summer, seasonal allergies. Then you're going to start thinking about endocrine stuff comes to mind for me too, especially if it's global. So I'm going to start thinking about the thyroid, maybe Cushing's syndrome. Those are going to come up. Those are that's my initial off the cuff differential.
That is a very impressive list. I will say that as someone who I swear trained on the angioedema capital of the East Coast, I see facial swelling and I just immediately picture like giant puffed up lips. And that's just the image I have in my mind. But yeah, absolutely. Yep. That is an extensive list, but all really relevant and something you definitely need to keep in mind as you walk into the room. So you open up the triage note. It reads, here for facial swelling for 2 days on lisinopril. The only other encounter that you see in the chart is way back in 2018. They had an orthopedic injury, some kind of fall, nothing particularly significant. And the initial set of vitals, blood pressure is 150 over 75, the heart rate is 80, respiratory rate is 16, who knows if that's actually counted, temp 36.5, and then oxygenating 99% on room air. So you walk into the room, you see the patient, he has his wife with him who accompanied him to the emergency department. What historical questions would you ask this patient based off of the things you know at this point and what's going on in your head and your differential?
I guess, rapidity of onset within that time frame, certainly if it was longer, you say, has been gradually building. Was it kind of simmering for a little while and then popped off? What was the last straw? I like to ask that question. And someone that's not presenting within hours of symptom onset, What was it about this moment that led you to come in now? And then more globally, in that space of some of that differential we're talking about, have they been putting on pounds? Have they been racking up weight, whether it be water weight or actual fat? And on the other side of that coin, are they losing weight? That would be a problem too. Definitely, we mentioned lisinopril at least once here. We've mentioned angioedema a couple of times. So current meds that they're on, particularly those ACEs, and then meds that they've stopped too for the Cushing phenomenon that we're thinking about. Does the patient actually have an associated rash or is it just swelling? That's going to be a question for me. And then I guess if I'm going to get real academic here, any heat or cold intolerance. Those are the first things that kind of come to mind for me.
I think this is the best part in a clinical presentation to get academic, right? We had to think about the big differentials. We haven't narrowed down anything. We don't really even have an illness script. So I think keeping it broad, keeping it big is the best way to go here. Now, you walk into the room and this gentleman, he tells you, well, it's actually been about a month and it's been going on intermittently. But it really is the past 2 days that has gotten more severe. He kind of feels like his face is bloated, and he notes his upper extremities feel kind of tight, particularly over the past couple days. Same timeline as his face. Now, no fever, no difficulty swallowing, no dental problems, doesn't feel short of breath. He doesn't have any pain or swelling to his legs. And that's kind of what you get out of him initially. Medical history wise, type 2 diabetes, hypertension, hyperlipidemia, no prior surgeries, no known allergies. And he has a pretty extensive med list. He's on lisinopril, he's on pioglitazone, epagliflozin, atorvastatin, sitagliptin, metformin, glipizide. He's on every diabetes medication that you could possibly be on. Who knows if he's actually taking any? Yeah, it's significant. I was like, okay, are you taking all of them? He's like, yeah. And I'm like, okay, sounds good, man. So that's kind of where we are based off initial history here.
Okay, interesting. So from there, I guess I want to dive into the nuances a little bit of the review of systems and the past medical history. So we talked about his med list, a little bit weird. Be on so many diabetes meds, maybe he's an incredibly poorly controlled diabetic, which I guess would affect your differential slightly. But we often forget any recently stopped meds, right? That was something that I mentioned early. So I would ask him directly, you been on steroids for any reason? I don't know. Doesn't seem like he's going to be someone who's got rheumatoid arthritis or COPD or anything that might necessarily lead you to that. But ask him about steroids, steroid cessation, use of other medicines that they've been on and stopped. And just kind of going into this a little bit more, I'll say for the listeners, but for me too, what is pioglitazone? What I was trying to remember our mechanism of action as you went through 4 or 5 diabetic medications, but can you just refresh our memory on that one?
So you're definitely a better clinician than me. I didn't ask anything about steroids, but it's a good question. Now, in terms of pioglitazone, we got to really think back to step 1. Anyone who's been really recent, this is all traumatic or post-traumatic, so maybe everybody suppress this information
Remember
at this point.
like yesterday.
Oh,
none of the medical knowledge, just remember the process of having to do it.
That's too true. So pioglitazone is an oral diabetes medication. We'll keep it very simple. And it kind of affects genomic expression to change your insulin resistance. Very simple. I won't throw out proteins, won't throw out anything else. It fudges with your genes to make your muscle cells and your fat cells take in more glucose. They become more insulin sensitive. And that's how you help manage your blood sugar and why it's an effective medication. I did, just in preparation for this podcast specifically, do a little bit more review as well. And some of the adverse effects do include new or worsening heart failure, edema, bone fractures, weight gain. So I think thinking back on that, I also could see pioglitazone being just as much of a factor in this differential as lisinopril, which we'll obviously talk about. It's interesting to think back on that and be like, I didn't really catch that in the initial presentation, but it definitely could have been something to explore, because medications can do a whole host of stuff. And when you're, polypharmacy, it gets complicated for sure.
Yeah. Thank you for that refresher.
I know everyone's turned this podcast off at this point. So with all that, right, what would you be looking for on a physical examination for this guy?
So we went over little HPI, like you said. That duration is always interesting and important to pin down. 2 days. Oh no, it's actually a month. That's when worsening, stuttering, etc. And then we went over ROS and some of that past medical. I guess as we go into the room, the classic boards, what I see, smell, hear, but I do want that little, that kind of just initial look and being, I guess, conscious of political correctness. Like, what does he look like? Is he Pickwickian? Is he morbidly obese? Is he obese at all? Is that obesity truncal or is it diffuse? Does he have swelling in his legs? Are they massive tree trunk pitting edema legs? Or are they non-pitting lymphodematous legs if they're edematous at all? Importantly, I'm going to sort of think about rashes or color changes to the skin, thinking about rashes on the face. By those vital signs, it'd be hard to argue that there's an anaphylaxis going on, but certainly something we brought into our differential and we're going to think about. And thank you for mentioning his dentition, a little bit about history there. Certainly intraoral infections, we're going to put that on there. So we're going to take a look in the mouth, both for localization if there's angioedema, but for the dental caries and the associated soft tissue. But outside of that color change to the face, but is there a color change to him collectively? Is there any hyperpigmentation? And then I guess sort of tongue in cheek, have I ever really used this clinically as we talk about the nuances of facial features? What are his eyebrows like? Do the lateral borders of his eyebrows lose their contour? So those are the things that I'm going to ask about initially when I want to, walk in the room, see, smell, hear kind of thing.
Okay. So I didn't smell the guy, so I've already failed boards.
Okay.
But you look at him, and I would say it's a stretch to call him edematous. His BMI is probably 30. He's pretty fluffy at baseline. He's got his construction vest on. You can tell he spends a lot of time out in the sun. So he looks tan all over. And based off of his profession, you don't really think twice about it. Really hard to make any specific commentary about his facial appearance. Yeah, he's kind of a fluffy guy. Like, you look at him and you're like, maybe, I guess. You can see that he's tolerating secretions. He looks really comfortable. He doesn't have any lip, tongue, or uvula swelling. His dentition looked great, probably better than mine. Has a normal cardiac and lung exam. He's got a non-tender, obese abdomen. His upper and lower extremities are non-pitting. And to be honest, he has some pretty good forearms. If you were a gym bro, you'd probably be pretty jealous. So it's tough to tell if what we see is like swelling or not, or if this is just him.
I mean,
what do you think about that?
Yeah, the first thing is, I'm maybe a little gym bro myself, so I don't know where your bar is for gym bro impressiveness.
Yeah, given his profession, he probably could totally beat me and the vast majority of people in the hospital probably in an arm wrestling match. So
fair enough. I picture painted, burly on the thicker side. I love the fluffy term, but muscular fluffy, it sounds like.
Yeah.
You mentioned his extremities are non-pitting. Just to clarify for me, are they edematous non-pitting, or they're just not really edematous at all? Like, you're getting this sign of lymphedema or not?
I'm not really getting it. I'm just like, your arms just kind of look thick to me. I didn't see him and go, wow, you're edematous. Like, something's up with you. Right? And this is where things get a little bit interesting, and you really have to think about collateral history. I'm like, I don't know who is this dude at baseline? So I look at his wife and I'm like, does he look swollen to you? And she goes, absolutely. I'm the one who told him he needed to come to the ED. And I'm like, okay. And is anything else worrying to you? She's like, yeah, he looks a little flushed. His voice seems a little bit off to me, hoarse even. And I go, okay. And I ask him to speak and really listen, and maybe it sounds a bit strained. And that's kind of what I get from her. Yeah, he looks off to me, which isn't
awesome. Good. I shouldn't say awesome because it's bad, but I'm giving you kudos, I guess I'd say. So that awesome use of collateral. That's like invaluable. I was going to sort of get into the area. Sometimes when people are pointing out things and I don't really see it, I have to, I don't recognize this in you, but I don't look at you every day. You look at you every day. Where do you see the thing that you see that I don't see? So that was a tree I was thinking about barking up as you presented the case, but the wife's information is huge. The significant other gets involved. That's incredibly valuable. And that brings it, we're thinking about this is like a 3, maybe 4 alarm fire now. Her dragging him by the ear into the emergency department, that brings that pretest probability up by like 50%. It's a real alarm. It's a real thing. And so we take this, the guy that I have in my mind as kind of this, but not really evidence of edema guy to me, going from not as serious to pretty darn serious. And we have to assume that what he and she are saying are true. Obviously, we always do that, but especially when it's a physical exam element that you can objectively usually recognize, this just gives a lot more merit to it. If you wanted to get real Sherlock Holmesy or really ace that oral boards, you could ask for that classic, the license photo, and hold it up and try and compare and contrast those really poor quality images, which I've never actually gotten great data from, but that's another direction. But I think that question that you asked of the wife is really great. So kudos, man. Well done.
My spidey senses, just like you, are sort of starting to go off at this point. And I asked the wife, has he
Yep.
lost weight? And she's like, I don't know. And the patient goes, yeah, I'm actually 10 pounds less than when I saw my PCP a few months ago. And I'm like, why do I ask these questions? Like, I don't want to know. Like, do I want to know the answer to these questions? They make me uncomfortable. And I can feel my brain putting pieces together at this point. And to be honest, I walked in expecting ACE inhibitor angioedema, and I left with a completely different diagnosis. And leaving that room, I know what I was like most concerned about. And I went back to the computer and put in a single test, and we'll talk about it, but it was one test. I didn't type anything else in, just put it in an order and click send. What do you think it was?
I'm going to allow somewhere in the back of my brain to pontificate on that while I just comment on the like pigeon holding that you experience. You read a triage ESI level 4, my face feels swollen. The next sentence written by the triage nurse is takes lisinopril. Like you're set up to fail, right? You are set up to prematurely close on this case and beat yourself up in that way. You did the right investigatory work. You asked the collateral information and started diving into more. And we talked about review of systems, about weight loss, weight gain, and that 10-pound weight loss in a month, unintentional, that's bad, right? That increases your concern always for malignancy. And then as you mention these pieces, you're talking about facial, neck, and arm tightness, swelling, weight loss in that space. You're going to find a mass somewhere. So we're going to order a CAT scan, and we're going to order it. I suppose I would do chest, head, and neck would be my areas of focus.
Okay. Yeah, I agree. I walked out of the room and went, something's not right with this guy. And I was very worried about a little something called superior vena cava syndrome. So ordered a CT of the chest, and he went off to CAT scan, and I opened it up when it crossed over immediately, and I looked at it and audibly groaned. It doesn't look good.
Oh, no. Oh, no.
Doesn't look good.
Man, not the way you want to see the case go, not the direction you want to have care happen. If only we had a podcast on like difficult conversations for listeners to reference, that would be great. We'll put the link in the show notes. Because this is sounding pretty cancerous to me at this point.
I was called by radiology with like the prelim read, and it's never good when the person is like, "Hey, Dr. Ward, radiology's on the phone." They're like, "Ah, man, okay." So on this CT, this poor guy had an aggressive mediastinal mass. It was encasing his descending aorta, probably invading his superior vena cava, his left brachiocephalic vein. He had fairly extensive lymphadenopathy. And they were like, yeah, this is consistent with the malignant process. And they recommended a biopsy. They noted some small spiculated lesions in like the right upper lobe of the lung that could be primary lung. Maybe it's Mets, maybe it's scarring, maybe it's an infiltrate. He also had some bilateral pleural effusions, fairly small, and a small pericardial effusion that they considered likely malignant. So big constellation of findings on his chest, with the key thing here being this invasion in and around the aorta and in and around the superior vena cava.
Yeah, yeah. That's what rang true for me as you were reading off that list. That's many blood vessels and many very important blood vessels, which are being surrounded and, imaginally limiting flow, leading to this puffy sensation. But those are vessels you just don't want to hear are being invaded by a radiologist, right? That is unfortunate news for this gentleman. There's a Goldilocks phenomenon I find sometimes in the newly diagnosed cancer patient, right? They're challenging and they have their own dilemma to them because this guy was hemodynamically stable. He read off perfect vital signs when he came through the door. His chief complaint was facial swelling, and granted, it holds nearly no water, but he was an ESI level 4. I think this is all to say, when you get that data on this gentleman, you have to ask yourself, where do we go from here? Sometimes you want them to be sicker, not really, obviously, but in terms of like the diagnostic and disposition dilemma, they're challenging. One of the hardest things I think that we do in emergency medicine is make this like serious life altering, certainly, and possibly life limiting diagnosis for the patient and say, let's get you, to an oncologist and your appointments sometime in the future TBD. That's like really hard. And I don't know if that's what happened in this case here, but it does happen, and it can, it leaves you and the patient and so often the family member who is not usually the stoic one, the one that breaks down, as would I if it were for my family. It just leaves this lack of satisfaction, Dylan. And so help us understand, what was the conclusion for this patient? How did you end up wrapping up his care?
Well, I broke the news to them, obviously. And interestingly, or rather conveniently, you're talking about the podcast that we recorded recently on, breaking bad news and creating a headline. And I actually did that and processed all that information before this case. So now I was like, let me think about delivering this in the way that Dr. Kashap would want. How can I make her proud?
Nice. Yeah,
so
great.
I think it was cool to immediately apply something that I had just learned in talking to Dr. Kashap. And it's a great episode, so I would definitely recommend listening to it.
Can you remember your headline?
I think it was something along the lines of, hey, so first I think I went into the room. I went, hey, sorry for the wait. It's been a little bit since you went over to CAT scan. Things have been busy, but I wanted to catch you up on what's been going on with your case. And they're like, okay. And I went, so I have a bit of bad news to share with you.
Sure.
On your
warning shot.
On your imaging. So yeah, warning shot, broke bad news. And then sort of kind of what I said was, look, it looks like your CAT scan has what seems to be cancer around your blood vessels, which is why you're so swollen.
Okay.
And I just let it there.
And say something so simply, so important, and be so silent after. But that's great. Cancer, blood vessels, why you're swollen, stop. Nice.
And the wife was shook. Patient went, kind of shrugged his shoulders, and maybe he could tell, or maybe in his mind he knew something wasn't quite right with them. And from there, I gave a very broad overview. I am concerned, based off of these findings, that cancer is in multiple places, which means that it's spread and you could be very sick. And that was sort of big picture stuff. Didn't really dive into specifics at all. And then I gave him a plan from there. We're a community site, at least where I was at on this specific shift. And where we are, we don't have cardiothoracic, obviously in-house. So we coordinated to get him out of the system. I think I was able to levy the fact that his aorta was encased to make a convincing argument why this wasn't a great best of luck out in the world, find your oncologist sort of case, which I think was very helpful. it
Yep.
means he's very sick, but it was a good way to pitch it to the oncology team and the internal team and everyone who was going to be caring for him externally. Like, hey, I got this guy. Yeah, he looks great. He's stable, but he's got pretty severe invasion of his major blood vessels, and I'm concerned about him.
And getting that tissue sample is like there's elements like you said about where his lesions are that make him a easier case to pitch for internal care, inpatient care. Gotcha. Okay.
Just to kind of end this here, I wanted to talk about this case primarily because it was a case that would have been so easy for me to miss. And we've talked about it over and over again at this point, but I could have easily missed that this was a mediastinal mass leading to SVC syndrome. I had multiple things working against me. And if it wasn't for the wife telling me that something was off, I don't think I would have scanned this guy. I would have reassured him, maybe obtained a lab or two as part of like a therapeutic laboratory workup,
Sure.
and discharged him home, which is pretty scary.
Yeah, and I mean you're in good company because I completely agree. I don't know if you recall like the flow of the department that day, but yeah, I love being a diagnostician. We talked about Sherlock Holmes type questions and trying to really sleuth it out. Which when we have the opportunity, when you're getting up there and it's an insane day, and you might have all of this stuff ordered in triage, you go in and get a cursory history, don't see a swollen guy, and you send him out easily if that's being done that way. So this diagnosis, I mean, I would put it in the buckets that I put like spinal epidural abscess, frequent Wernicke's encephalopathy is one that I have such a hard time with. Endocarditis, those are classic diagnoses that I'll put in that sort of like second visit syndrome, where the first doc is just they've got the unfortunate disadvantage of just commonly missing the diagnosis. And I'm happy to say you didn't fall into that camp, but it was an easy trap to fall into for sure.
Since we talked about it, it would be a good time to just review it for the listeners. There's also a good chance for me to review it as well. I think, we don't really need to know it from like a management perspective as an ED doc. It's in the category of those can't miss diagnoses that honestly the most important for us is just not missing it, right? Yep. So at its core, SVC syndrome, really a catch-all for the collection of clinical signs and symptoms that result from that partial or complete obstruction of blood flow through the SVC. And that obstruction can be from a thrombus or tumor infiltration. And if you remember from anatomy class, the SVC is really where the two brachiocephalic veins come together. And that's all of your blood flow from your head, your neck, your upper extremities, going all back to your heart. So if that's obstructed, everything else is going to back up. That's the physiologic basis for it. Does that make sense?
It does. We know that classic kind of plethoric person, right? And I believe that's more gravity dependent, right? Like you're getting more flow through the constriction when you're upright, and they become more plethoric if they're laid down. But yeah, an interesting diagnosis. I think of it as like kind of that board style one where it comes to your mind from time to time, but I've never seen it. And it's the recognition, just like you said. So
the vast majority of these are just caused by mediastinal malignancies. So big one being small cell bronchogenic carcinoma. And then you have non-Hodgkin's and then metastases. And then we have these cases that are from, stuff that we do to them. Some sort of thrombus formation or stenosis from, some sort of inserted wire or catheter. So maybe they have a pacemaker, maybe they have some IV catheter for hemodialysis, antibiotics, chemotherapy. So if you have that sitting in your SVC or in some capacity, you are at an increased risk of thrombosis. So there's about 15,000 cases per year, so pretty rare. But it is increasing, and sort of the attribution is it's probably catheters more than cancer. Right? We're doing a lot more invasive stuff. People are going home with PICC lines. People are getting permacaths for dialysis. People are getting pacemakers. So just because they don't have a cancer history, you don't see a mass, if they come in with kind of facial swelling, plethora, and symptoms, maybe it's time to reevaluate that catheter that's in place, which we don't think about as actively as cancer, if that makes sense.
Yeah, for sure. I mean, that was the thing that most commonly came to mind for me prior to this cast, and certainly when we talked about the weight loss was kind of a tipping point in that sort of thought process differential wise. But yeah, 15,000 cases per year, not common, but I mean, that's a higher number than I expected to hear from you. And the longevity of life that we're having, the increasing, like you said, the amount of work that we're doing intrathoracically and intravascularly, that's important for me. It's a great take home. And thank you to think about these patients that have a higher thrombotic risk in their
Hmm.
SVC, not necessarily cancer. So cool. Yeah, helpful.
Yeah. And I think just to kind of summarize those symptoms, face or
Hmm.
neck swelling, distended neck veins, upper extremity swelling, distended chest veins, thinking just the blood's not getting back, things are backing up. And then you get facial plethora. Maybe they're having a headache, nausea, syncope, vision changes. So if you have all this poor venous drainage from your face, it's going to affect a whole bunch of stuff, both
Sure.
in your brain and in your face. Now, one of the big catches here was hoarseness, and this could be caused by laryngeal edema. Also, could just be from malignant infiltration and damage to the recurrent laryngeal nerve.
Mm.
So, not to traumatize anybody from anatomy, but remember that that nerve dives really uniquely. On the right side, it goes down and dives around the right subclavian, and on the left, dives around the aortic arch. So, it's a pretty long path from an anatomic perspective, and it leaves it quite susceptible to injury. So, hoarseness could be from edema, or it could be from a mass that's impacting that nerve in some way as it courses along to your vocal cords.
Yep, helpful. Thank you for that reminder. And I guess I was almost thinking of it maybe as a red herring, and you noted, or maybe you noted that I asked for the kind of chest, head, and neck, because the hoarseness made me more alarmed, but it made me more concerned in the soft tissue neck region, which I guess fits with this with SVC syndrome. But thyroid is a direction I was going in that space as well. So the plethora, the swelling, the changes in his arms wouldn't fit with a lesion in the neck space as I had thought it, but it does still kind of create a nice box around SVC syndrome. So cool. That makes
Okay.
sense.
Yeah. And then just to wrap it up, like from a diagnostic perspective, it's going to depend on the etiology. Maybe you can see a thrombus in ultrasounds, chest x-ray. Maybe you open it up, you're like, wow, there's an obvious mass on this chest x-ray. But CT of the
It's big.
chest is a little big. CT of the chest is probably your best bet. Diagnostic sensitivity of 96%, specificity of 92%. So that's going to be your go-to. We ordered the right test. CT of your chest if you're concerned about this. And then management is pretty
Mhm.
simple. Talk to some experts, admit the patient, depending on what the presentation is like. And then the specifics are going to be guided by the etiology. If it's a thrombus, maybe talk about removing the catheter, maybe anticoagulate them. If it's malignancy, you're going to talk to some experts. Traditionally, it's been managed by open surgical repair, but these days we're moving towards more endovascular recanalization. So it's going to be up to them. But you got to talk to somebody.
Sure.
It's not for you.
Okay. And give me a little bit more in your CT. Did you order just CT angiogram? What was your contrast, if any? And was it timed venous, arterial? Dive a little bit more into that, or at
Yeah.
least what you did with this guy.
Yeah. I just did CT with IV contrast. I
Okay.
didn't do like a spiral for PE. I'm guilty of
Mhm.
the let's just rule out the PE for the short of breath patients that come in where you're like, I
Yeah,
probably
sure.
don't think it's a PE, but they have pneumonia, but I'm going to order the PE scan anyway. Like that's like a very lazy way just to, tackle your diagnoses. But for this, PE wasn't anywhere on my differential at all. And
Sure.
I didn't
Right,
really
right.
have a good convincing case for any arterial involvement. So standard IV contrast is probably fine. I don't think you need to
Okay.
order a specific test for this at all, at least from what I was reading
And
and from my experience.
yeah, and I mean, you'll recognize the mass and lesion, right, on whatever timing of contrast maybe you do get a dimer. Obviously, these patients, if they're oncologic, are probably going to have an elevated dimer, and you're going to find it that way. I wouldn't waste too many brain cells in that space, but it'd be better to have contrast through the vessels. Obviously, here, when we know on the other side that they're venous, that
Hmm.
would be great, but know that you're probably not going to err massively on either side of that coin.
I agree, right? You're going to scan the chest and then you're going to figure out what's going on with this patient. And that's really all I have for you. As I said, it was definitely one of those cases where if you were a tad busier or not as mindful, or if the patient came alone, you may have completely missed it. So makes you think.
More than makes you think. It makes like palms got a little sweaty during your storytelling. Like it makes you respect what we do. So awesome case, Dylan. Thank you so much for sharing. Do you mind? Would you please do a little summary for me and for the audience?
Only because you asked nicely, Jason. So,
Thanks.
I think a couple different points. We'll keep it to 5 takeaway points, I think. We won't be exhaustive here.
Okay.
So I think 1, think beyond angioedema in facial swelling. So obviously, facial swelling on an ACE inhibitor may lead you towards angioedema, but don't anchor. Get collateral history, or is there hoarseness, voice changes, upper extremity swelling, and look for some subtle exam findings that prompt consideration of something else, more sinister, like SVC syndrome. As I said, collateral history can be critical. This case was almost missed without input from the patient's wife. Her observations of facial flushing, hoarseness, change in appearance shifted the differential and led to this timely CT chest. So don't underestimate collateral info, especially for vague or subtle complaints. Point 3, just know the classic findings for SVC syndrome: facial or neck swelling, upper extremity swelling or tightness, distended neck or chest veins, hoarseness or facial plethora. If you can keep that in mind, maybe it'll drift to the top of your brain and you'll be able to make this diagnosis. Number 4, CT chest is your diagnostic workhorse. When concerned for SVC syndrome, CT chest with contrast is the imaging modality of choice. Good sensitivity, good specificity. And then point 5, our role is make the diagnosis and then get help. So we're not managing this definitively. We have to make this diagnosis. And then after that, involve oncology, cardiothoracic surgery, vascular, whoever is going to be your go-to here. And depending on the cause, you'll work together and come up with a good disposition for that patient. And that's all I got. Hopefully people enjoyed this today, and I had a good time chatting. So it's a cool case.
It's a great case to get into. Again, having a presentation from you, a case that you took care of 15,000 in a year. It's not common, but it's something to have in your mind. So thanks for bringing it to our attention, teaching us some about SVC syndrome. I certainly learned a lot. Listeners, I hope you did too. And until next time, guys.
Cool. All right, Jace. Catch you later.